So, how have improvements been achieved? I think this is looking at how science has contributed to the improvement of healthcare, health services. And Arnold Redman, who was the director of the New England Journal of Medicine, in the late 80s, wrote a really helpful article of what has happened to date at the time. And he described three eras of coordinated efforts in healthcare. And he was describing an American, but I think the American system. But I think a lot of the allopathic medicine followed that in many Western countries, and probably similar to Japan. But you can probably plot your own. But he called it that after the war, and from the 1950s onwards, there was an era of expansion of allopathic medicine, where antibiotics was discovered. You can control infectious diseases. The sky was the limit, and there was just so many new ways of treatment. And people thought, we've really cracked it. We can cure all these diseases and eliminate ill health. And so this was the era of expansion, where there were lots of new discoveries, lots of new cure. And then sometime in the late 1960s, people realized that costs were soaring, and actually, this is not the limit. There was difficulty in making sure things were not where we're keeping on. There was more and more treatments coming about, and actually more and more money was spent in health, and governments were getting more concerned. And so that was the era of cost containment, and lots of financial means of constraining health was healthcare expenditure was really the focus. So from the 1970s was the era of cost containment. And initially it worked. You could use financial incentives and to really just curb activity. But actually, eventually, the clever players in the system outplayed it, and actually it didn't really work. Healthcare was still soaring, costs were still rising, and it's not. We can't just keep expanding indefinitely. And I think governments knew that. And then came the era from the 90s onwards, an era of assessment and accountability. And we are in this era of assessment and accountability. And what do we mean by that? Essentially, we are looking at why we're doing things, how we're doing things. Because not only we can't just contain costs on its own, we need to know what's effective, what's efficient. So we can, together work out an accountable way. And so therefore, we are now in the era of cost accountability and assessment. And this was helpful and when he penned this down. And I think it's just quite helpful for us to see how coordinating care of science and understanding and researching health services has helped us looking into this. Now, we talked about the science of improving health, researching and understanding health services and improving this. In this great picture of what drives healthcare policy, I just want us to be mindful that we are in the scientific evidence far right area. And actually, there are so many players in this sphere. If you think about the healthcare policymakers, we think, oh, it should be science-based, evidence-driven policy. That's us wishing that. But we must be mindful that actually there are many players in this world, and we are part of the environmental turbulence, we call it. But actually, it's more what we want to aim for is probably evidence, scientific evidence-informed policymaking. Or influence, in fact, influence policymaking. Because look at all the influencers in the system. We've got the healthcare professionals and the important trade unions, the clinicians. Rightfully, all these players have a place in influencing the health system. We've got the central government, we've got public and mass media's interests, and you only need to think about a contention in closing down a hospital. At least in England a few years ago, when they wanted to close an A&E department because it was not effective. All the public, the media attention, and the politicians rising up against it, and that dynamics, it's very real. And we've got the powerful players of industry, mindful that these are all rightfully there, even though we question their motives and, is it for profit? Are they got the patient in mind? it's a necessary dialogue, and they're all rightfully there. And it is the dynamics, isn't it, and a balance of the different players and powers. So, okay. And importantly, what are the key concepts? I think if we think about from how our health system works, this is really key, a key slide. There is always a struggle for influence and control. And I don't know very much about the Japan system, but if I were to go into a country where I know nothing about anything of the healthcare system, I want to know these three key dynamics and interplay. First of all, I want to understand how does the dynamics work between clinicians' autonomy. It's very crucial that many of us come from a clinical background, that professionals have an autonomy, a degree of autonomy. I mean, 50 years ago, professional autonomy was the center. Healthcare just ran with what the doctor or the nurse said, and that was how it was. Now this is changing. How does it work in Japan? How does it work in your country? Do doctors say, and increasingly, there is a spectrum now. There's a certain degree of autonomy it's important for a professional to practice healthcare. But yet also increasingly, there's an accountability to this autonomy. It's only in a limited, in a capacity way, in a limited way. Why is that? Because we have some corporate rationalizers. We're talking about being accountable to the system and being in the era of accountability. And what are corporate rationalizers? And we are in this sphere now. Being in researching about health services, being in the school of public health, we have now all collectively the corporate rationalizers, and it's an awful name, isn't it? But what it means essentially is those of us looking at the system as a whole, thinking about the populations. When you are the doctor, the clinician, you are thinking about the patient in front of you, and rightly so. If you were the patient, you want your doctor to be thinking about you only. You don't want the doctor to be thinking about other people. If I was ill, I want the best treatment immediately now, whether or not it costs lots. Obviously, that's normal, and so you want the doctor to be thinking about yourself. But then there are also the importance to keep everything accountable and assessing the era of managing, studying, looking at populations, looking at the system as a whole, and thinking about populations as a whole when we know that, what's the most effective way, what's the best treatment. And so these are corporate rationalizers. And then lastly, the public. And this is rapidly changing as well. We talk about, we're going to talk about the role of the consumer, the public, the patient. And so this struggle for influence and control is really what underpins a lot of the challenges and the things we're looking at in healthcare and when we study health services. If we know the dynamics between these three and we understand it, that's when we begin to see the complexities of it all. That's when we are being able to work around it. All these three have a role. We just don't want one to be overtaking another, and it's about being in balance with one another. And I think, also importantly to be mindful of is also the market system and the command and control system. And it's we've got one end. We think of the market system of healthcare. What country comes to mind? We say markets, healthcare market. What's a very private-driven market? Maybe America, United States. If we think maybe, someone say maybe. About what percentage of it of states is private care? How do people know? Out the top of the head, about 50%, actually 50%, and the other 50% is actually still publicly funded. So we've got the Medicare and Medicaid. So around that figure. So actually we think about the market. So it's a spectrum, isn't it? So there's a very, very market-driven model of healthcare, which is the states. But only then, there's still quite a lot of publicly funded money. And then when you think about a very public system, probably, you think about the NHS, the National Health Service in England, 90% the activities are publicly funded. But most importantly, we want to think about the three players, three different key aspects of healthcare. Who are the payers? Who pay? So who funds healthcare? It has to come from something. Taxpayers, donors. A lot of lower middle income countries have wealthy donors. Insurance subscribers. And who are these people? Are these the employers or the employees or both perhaps? Then we want to know who purchases the services. And many countries split the provision and the purchases. So sometimes it's the government, the local authorities buy these services. Insurance companies, very powerful, decides which hospitals in America. You can only go to this hospital and have this service. Very powerful companies. Sick funds, which is a lot of European countries call their social insurance schemes. Primary care practices. Sometimes the structures are bought by the generalists. They purchase the more specialist healthcare. And also people, out-of-pocket payments, can buy services. If you see a private doctor, you pay them out of your pocket. Providers, who are these people? Are they publicly owned, privately owned? And in every system, in every country, we want to consider these aspects.